the point is that 85% is your lifestyle and where and how you live. And I think once people kind of get that, it changes the conversation, because it realizes, you can take more control around your health, and, you can drill down into all the aspects that contribute to that 85%. But one of the ones I never saw, because I see a lot about diet and exercise, things that you can do that influence your health. But I never saw anybody talking about the built environment, because ultimately, if we really want to have a preventative health culture, and places that actively support preventative health, we have to think about health creation. We have to think about health as something that we make, as opposed to something that's done to us because, we've gotten sick.
Hello. Welcome to Talking Place, the podcast bringing placemakers and storytellers together to talk about place. I'm your host, Tanisha Raffiuddin. I am the founder of Concept Culture, a creative agency in London, passionate about creating purposeful brands and telling powerful stories. In this episode, it is my absolute pleasure to talk place with Clare Delmar. Clare is a consultant and campaigner focused on creating healthy homes and communities. With a background in planning, construction, and healthcare, Clare's work sits at the intersection of health and development. As the founder of the blog Listen to Locals, Clare writes about communities, health, and planning, which led to a number of initiatives, including a challenge to the development industry to recognize the impact it has on local health. We cover a lot of ground in this episode around the creation of health in our places, what health equity and health creation entails, the need to shift from a sick economy to a prevention economy, and how developers' contributions can play a vital role in the creation of healthy places. All right, let's talk place. Clare, welcome to Talking Place, the podcast where we bring placemakers and storytellers together to talk about place.
Thanks. It's so exciting to be chatting to you.
Clare, you and I met on the back of the Healthy City Design Congress in Liverpool through a mutual connection, and we got chatting, we connected, and I learned a little bit more about your work. So when we were curating the guest list for this podcast, it was almost a no-brainer for us to invite you along to talk about the very important subject about health and health equity in our built environment and in our cities. But before we get into the nitty-gritty, I would love to hear about your journey. So how did you get into health specifically, and urban health, and what inspired you along the way?
Yeah, well, it's a long story, but I'll try to be brief. But there are some concepts from this that I think are incredibly relevant today. So I think that's the benefit of the journey as opposed to the destination, so to speak. I mean, I came here in 1988. I trained as an urban planner at MIT in Boston. And it's important that was a real starting point, because I think the way I was trained as an urban planner, I certainly felt this when I arrived in the UK, was really different to what an urban planner was defined or was regarded as then. I think that's changed, and that's a big part of this. But at MIT, it was very multidisciplinary. And so while everybody had sort of a subject specialty or a discipline that they did a little bit more deep dive and developed a little bit more expertise around, and even in terms of, sponsored research and stuff, everything was about a project team and a cross-disciplinary team. So you would have a particular challenge that would, be for several months, and you'd be working with somebody whose area of expertise was very different than yours. And these are usually about 6 people. So you came out not only having an appreciation of different subject specialties, but a real respect for the concept of project teams and how to make them effective. And so that was as much a metric, of sort of qualification as was the subject specialty. I happened to be a specialist in economics, urban economics, and particularly I was funded by the World Bank to be looking at private financing of public infrastructure, which I laugh about now because, fast forward all these years, it's still something that people talk about. But it was kind of a nascent concept then. And so when I came here, it was kind of on the back of the privatization of the former nationalized industries in the UK, and then, of course, the beginning of the Eastern European privatization. So that was sort of my thing, and I worked in the city. But then I had a client that went to work for a construction company that was under the aegis of P&O, and P&O was a big kind of conglomerate. You might know it from the ferries that I think some of them still run. I don't know. And its chairman, Lord Stirling, was a real Thatcher advisor, and there was a strong connection to her government and indeed the whole sort of agenda around privatization at the time. And so the guy who went to run Bovis had been a client, and he was then reporting to a really visionary man called Sir Frank Lample, who I do want to sort of mention here because he's sadly no longer with us, but it was the most amazing, inspirational, visionary man who actually referred to the UK construction industry as a bunch of hairy-ass builders, and I quote, who had very little, sort of broad-based qualifications. And he very much looked to the United States as a place where construction was done in a much less adversarial way. And it's so interesting that word adversarial was used all the time. And in fact, Frank's sort of vision was to create non-adversarial construction. I mean, that was actually a goal, if you can believe it. And we're sort of talking, sort of early to mid 90s now. Anyway, I went in to join them. I think I was the first woman in there. And started to look at ways of integrating some of these American companies with what was happening in Britain. And then something happened that really did change the way our built environment ultimately developed for the next 25 years. And that was something called the Private Finance Initiative, also known as PFI, which basically was, depending on who you talk to, I'd say the majority of people do not look very fondly on PFI and feel that, now a lot of these organizations, whether it's health service or education or, are saddled with debt. And it changed the way procurement was done. That was the whole purpose of it. And it was to actually get capital spending off of the government's balance sheet, which again is proven to be very controversial. But it was what it was. And so I was in this construction company where they were sort of forecasting, government spending in terms of their own construction plans, was just going to go up and up and up. And I was like, actually, there's a whole new procurement regime happening. We have to completely change how we do this. It was, I can't emphasize, even for a visionary company like Bovis at the time, how hard it was to grasp this. It was such a fundamental change because you no longer were just going to go bid on big projects. You had to form a consortium with the people who not only designed, but then built and financed and operated. So you had to create this new entity, which were, very weirdly referred to as SPVs, special purpose vehicles, but actually they were new organizations. And in the health service, the way it ran was that clinical services, i.e. the doctors and the nurses and everybody who delivered clinical services would remain, employees of the NHS, but all the capital assets, so whether that was entire hospitals or even in some cases, smaller capital assets were actually built, owned, and operated by the private sector. And again, we can debate the merits and the demerits of that, but that's what I got into for about 10 years. And it was a massive change. I had to form a consortium to do this. And the reason I bring this up is because a lot of people now in the built environment don't really know about it. They see PFI as having been this terrible legacy that has saddled with a lot of our built environment assets with terrible debt. Actually, when PFI worked, it worked well. And one of the reasons why I linked this to my earlier chatter about multidisciplinary teams is it really forced, particularly in the health service, because that became sort of my area. And this is the sort of short answer to how I got into health from planning, because I wound up building PFI hospitals. But what was really different was in order to build these things and design these things and live with them for, 30 years with the length of these contracts. That's why now it's very much in the news, because a lot of these contracts are beginning to expire and they're going to be transferred back into the public sector. Another whole conversation, by the way. But to do this required a really different type, and I'm going to say it was like a project team that I had experienced at MIT. You had to work with, people who were material specialists on, antibacterial wall coatings. I mean, you really worked because everything had to come down to how you transferred the risk to the private sector and how you got value, delivered value for money to the Treasury. And in fact, the Treasury's obsession with PFI was always risk transfer and value for money. Those were the mantras. And you had to demonstrate that in these contracts. So anyway, I did that for quite a while, which is how I guess, officially got into the health world because I was building these hospitals. Then I had a little bit of a break. But then what happened in sort of around 2009, I got involved in because I knew a lot of people in the healthcare sort of capital asset world, if that makes any sense. I wound up getting involved in setting up a business around medical imaging. And again, we can talk about that in more detail, but it's not that relevant other than I've spent the last 15 years in healthcare with several healthcare companies, mostly focusing on diagnostics, working actually with one of the hospitals that was one of the PFI projects, interesting, UCLH here in London, on a clinical trial. And spending a lot of time setting up clinics and stuff. So this is all around men's health. That just happens to be what I got involved in. Not so much because that was by design, but because we had this diagnostic company based on this medical imaging technology that somehow it actually attracted the attention of some clinical researchers at UCLH, which were doing a clinical trial around new ways of diagnosing prostate cancer, and that became our specialty. So it's like a lot of things in life. You sort of have this plan, and then suddenly, oh my God, like this is really attractive to this sector. We had no idea. And that's what I've devoted a lot of the last 15 years to. But it's also the next stage to how I got back into urban health for two reasons. One was now I know a lot about prostate cancer. We can do another conversation about that. But one of the things that's really true about prostate cancer is the health inequality. To come back to your point, your question about health equity and health inequality is just massive. I mean, and I could go on, and I promise I won't. But just to give you one statistic, if you see, and we've just come through the month of November, which in the world of men's health is known as Movember, and there's a whole foundation that focuses during that month on men's health, and so a lot of this stuff comes out. You'll see, the very familiar statistic that says 1 in 8 men will get prostate cancer, and everybody kind of nods their head and accepts that. I mean, it's even like on the side of buses, But actually, if you're an Afro-Caribbean or Asian man, your chances are 1 in 4. So, you don't have to, it's not a big leap intellectually to realize they have twice the burden. And why is that? And, I began to look into this a couple of years ago, like, why is that? And there are so many reasons for that. And, a lot of it is, a lot of these men don't participate in the clinical trials that actually develop the new approaches, whether it's medical technology or drugs. So we just don't know. And I found this kind of astonishing, not least of which that, there's very different cultural practices amongst these communities in actually seeking diagnostic tests, for example, or screening. So I got interested in this. At the same time, I had moved to a new area of London. I live in Southwest London on the River Thames, and I was living adjacent to a regeneration project of a former brewery. And I got very involved in the community group there, looking at what was actually happening in terms of what was being proposed, but more importantly, how was the local community actually being engaged in this process? Because there was a lot of anger, and it was all kind of new to me, and they sort of leaped on me because I, was an urban planner. So they said, yeah, you can help us. And I was like, okay. I started looking at documents, and this was just after the pandemic. So, public health was pretty much on the forefront of people's minds, probably more than ever before, at least in my lifetime. And, the images of, people wanting to get outside and have access to fresh air and have access to exercise. This was all stuff that had never really been discussed so publicly before, but now it was. And what really struck me about the various documents I went through on this regeneration scheme was anything to do with health was just ignored. And I found this buried very deeply, this thing called a health impact assessment, which I'm smiling when I tell about this because, if I didn't laugh, I'd cry. I mean, it was sort of a very pro forma document that had clearly been done remotely. I mean, some of the references were so outrageous that clearly demonstrated that whoever wrote the report had never stepped foot in this particular area. And I just thought it really filled me with a lot of, not rage, but I thought, what a missed opportunity. Because, what I said a minute ago about how people were really cared about health, it was something that we talked a lot about, this is such an opportunity to talk about, what's going to happen with this new way of using land. and this new way of creating place, because this is a big development, by the way. I should say it was going to be about 1,500 housing units and mixed use as well, and it, right on the River Thames, beautiful site, wanting to give access to that, but yet no discussion about how this was going to impact local health or how people were going to get access to this beautiful stretch of the river, et cetera, et cetera. So that's what kind of got me motivated to think this is an opportunity that's being so missed. And, I love talking about community engagement, and, I've been to a huge amount of public meetings. A lot of them end in people shouting at each other because a lot of people have very different interests. Not everybody cares about schools. Not everybody cares about cars. Not everybody cares about, make it up, X, Y, or Z. But what everybody does care about is their health. And they do care about, will this new population, will there be the same provision of primary health, for example, that we've had in the past? And these are some of the questions that just weren't being addressed. So that's what kind of got me activated. And then what happened was something really interesting. I started writing a blog. And anybody who's listening to this, I encourage you to come to my blog called Listen to Locals. I thought, it's pretty much what it's all about. And it does have probably a health emphasis, certainly. I'd say it does have a health emphasis, but it's always linked to local communities. And through that, I kind of got writing a lot about, why when we look at health, do we not consider the built environment? So this is the other question. Like, I would go to a lot of health conferences wearing my other hat. And often you see a wonderful pie chart, as a starting point for conversations about health that say, okay, this whole circle is all the factors that influence your health. So I'm talking about on an individual level. And, then you'd see a little slice of the pie that anywhere between 10 and 20%. I've never seen it above 20%. Let's just say 15, just to be compromised. Most people would agree on that. And that 15 is what represents, your genes and what you're predisposed, as an individual in terms of your personal health. The point is that 85% is your lifestyle and where and how you live. And I think once people kind of get that, it changes the conversation, because it realizes, you can take more control around your health, and, you can drill down into all the aspects that contribute to that 85%. But one of the ones I never saw, because I see a lot about diet and exercise, things that you can do that influence your health, but I never saw anybody talking about the built environment. Yet at the same time, I was hearing about, children suffering because they were breathing, a poor quality air, or people living in houses with mold. And none of this ever came up. So it was like the planning discourse or the housing discourse and the health discourse just didn't meet. And that kind of also got me activated. So fast forward, I wrote a blog about, how does the actual industry cope with this? Like, local authorities sometimes do bring in health experts, and they do sometimes interact with public health, not all the time. But I didn't see anything coming out of the industry. And by that, I mean investors and, the big developers themselves, or even the house builders. And so fast forward, I convened an event that was very kindly hosted by Rob Perrins, who's the CEO of Barclay Group. And this was almost exactly 2 years ago. This was November 2022. And we convened a dinner and a discussion around how do we get the industry to work collectively to address some of the issues that we can dive a little bit deeper in a few minutes. And we had some pretty heavy-hitting people. And one of the people who came to speak was Sir Michael Marmot. And if anybody listening doesn't know who he is, he's a professor at UCL. He runs something called the Institute of Health Equity. He's actually an epidemiologist, which if you don't know what that is, it doesn't really matter. All you need to know is that anybody who's an epidemiologist loves evidence, and they just spend a lot of their time building evidence. And quite rightly, they don't say anything until they can back it up with a lot of evidence. And I have 110% respect for people like that. And he's a real legend. And he had done a report in 2010 that was commissioned by the government then to look at health inequality across England. And I think it was Wales as well. You can find this. It's very easy to find. And, he revealed, because he's such an evidence-based professional, he revealed some really startling data, which, really showed things like, very simple language, how if your life expectancy in one region and how it differs from your life expectancy in another. And it really began to show that it isn't about genes, it's about where you live, and this can vary. And he then introduced a term that what really contributed to these health inequalities were what he described as the social determinants of health, and that these could be not only controlled, but, supported by, make it up, governments, and certainly, he never really talked about the built environment then, but it was implied. So I picked up on that and thought, why don't we start looking at the built environment and what, how developers and local authorities, how they can impact the social determinants of health. So fast forward, we had this meeting in November 2022. There was a little bit of a lull, but one of the people who came was a guy called Pete Gladwell, who is the social impact guy at Legal & General, which is the biggest pension fund in this country, and they invest in a lot of property. And he was really interested in social impact, social value, and he was particularly interested in health and how we can integrate health into placemaking. And so about a year ago, he agreed that they would fund a piece of research with the Institute of Health Equity to look at the role of developers in supporting, promoting, delivering health equity. And that is about to be published. I can't say a whole lot more about that, but I was a key part of that because we had a number of roundtables with various commercial and private sector house builders, developers, investors to discuss exactly these points. And it was quite revealing. And I think we have a long way to go. But I think this report, and it will be published imminently, will have a big impact. And so I think, if anything, we're beginning to put planning and health in the same sentence. And at least we're beginning to have these conversations that, even a couple years ago, I don't think were really being had seriously, or if they did, they were very niche.
Wow, thank you for sharing. So that's quite the journey from, studying urban planning at MIT to now working on a impactful report that is imminently due to be published. So there's a lot to unpack there. So I might pick up a couple of points for the benefit of the audience. How would you define health equity? And you also mentioned health equality. So there's a difference.
Oh, did I? Yeah, no, they are very different. How would I define health equity? I would define health equity as the capacity for everybody to access a similar level of good health, for everyone to have a similar level of accessibility to the social determinants of health, because we can't control your genetic predisposition, as I tried to argue earlier. But in terms of the 85% that contributes to our good health, health equity is all about giving everybody access to healthy opportunities, if that makes sense.
It absolutely does. And I think that was also something that I took away very strongly from the Healthy City Design Congress. That's also some, as you said, health is largely ignored in the built environment. We talk a lot about sustainability. We talk a lot about materiality. And there is obviously a large community that talks about health as well, but not probably at the same level. It doesn't get as much attention as probably public health or urban health or health equity. And I myself, it's unfortunately to admit that was one of the first times I had heard health equity being raised at a built environment conference. So I think that for me, I came away with mixed emotions, similar to you, a bit of rage, a bit of anger, something as basic as health, something that's fundamental. And like you said, as human beings, as society, we can be polarized on many issues, but health is something everybody agrees that everyone can get behind on. So coming back to the social determinants of our health, and you made a point about planning, housing, and health weren't connected. So how do you think they should be connected?
I don't like the word should.
Okay, sure. Could.
I think there are ways it can be connected. And I think the first thing is so this is big change that we're talking about. Part of the reason I told you all about the private finance initiative and my work at Bovis Construction, because I've experienced what big change looks like and how challenging it is. And if you get it wrong, there's a long legacy. And frankly, PFI probably has a bad legacy because there are a lot of things that went wrong. Why is that relevant to what we're talking about? Because I think that there's no one way to do that integration. If I think, there's a series of, call them baby steps or low-hanging fruit that we can begin with to start the conversation. And I really do. I really believe in this idea of the low-hanging fruit. I think, having a conversation with people who might otherwise be polarized that then create something that benefits them all is an incredibly powerful way to move forward to the bigger agendas. So to talk about health as, an overriding topic is kind of a big agenda, to say the least. But, to focus on small things that help local communities, it can be really powerful. And I've seen many examples of that happening. So I guess that's a long-winded answer to your question. How might they be connected? I think in the first stage is having channels and platforms for people to have these conversations with developers, with the stakeholders in these local, where change is happening and places are being changed or places are being created. And actually, I refer back to, the thing that did make me enraged and activated a couple of years ago when I looked at that first health impact assessment in my local area. I really believe the health impact assessment is something that needs to be rethought and redesigned and reapplied, because I think it can be an effective channel to bring communities in for these conversations. So I think, there's really two elements to, one is finding a way to have these conversations where health and the change in our local built environment are talked about, and then having a tool where you can begin to manifest that and actually, develop a set of metrics and a language so those conversations can not only continue, but that they can actually deliver something. And I really do think it is about these small, very focused steps that, may be relevant to one community or one project or one new place and may not be for another. The other one is timing. But I don't think that there's one specific element. Having said that, I would like to see, as the national planning and policy framework is still under consultation, I'd like to see more, certainly more language and more frameworks for how we do integrate health into these planning discussions. In looking through what went out for consultation, I didn't see a lot around that, and I'm really picking up on superly high topical issues. Yesterday, Angela Rayner announced that, they're going to be looking at ways to sort of override planning committees so that planning officers and local authorities can actually make lasting recommendations on planning applications. Now, a lot of people will have different views on that. Some people would deride that as being anti-democratic because, you sort of seem to be cutting out the local community. Again, it really does depend on how a particular local authority works and what those community organizations look like. But what I would say is if you did have, basic toolkits and frameworks for whoever's making those decisions to work with, going back to sort of a more innovative, rethought health impact assessment, that would help in bridging those.
So you mentioned that there are a couple of places, organizations that are doing a good job at creating health equity. Are there any examples that you would like to share?
Yeah, I'm going to mention two things. I'm going to just reference once again Sir Michael Marmot and the report we're doing. So, Michael Marmot and his Institute of Health Equity does a number of things, including a program which they call Marmot Places. Sometimes they're even called Marmot Cities. And again, this is all very referenceable, but again, it's interchangeable, cities or places, Marmot Places, I think, but it doesn't matter. They're kind of the same thing. And basically that, in fact, it's a really good example of something I sort of just left you with, this idea of having common frameworks and common toolkits, because every place, every locality, every community is going to have their own peculiarities. But what they've done is put together, I think it's 12, I should know this, but I think it's 12 characteristics of what a Marmot city does, and they all have to do with health equity and improving the social determinants of health and ensuring that the social determinants of health are equitably distributed, back to your question. And then there's a number of things. I think it's 12 specific principles. And so the idea of going in and kind of creating a Marmot Place is to work with a local authority, in this particular case, that and introduce them to what these principles are, to ensure that some of these principles in their local area are measurable, because that's not true everywhere, and that they're well understood. And then a Marmot city then is born when a local authority agrees that, yes, we want to become this. We want to, sort of ensure that all of our policies abide by these 12 principles. So that's only been around for not even 2 years or so. So, it's kind of a watch this space. But I think that the very fact that a number of local authorities have come and want to be part of this. I know just this week or last week, Oxford is just signed up and is working on these principles. So that's a real positive. And I think it's really important to highlight the positives, because it's too easy to focus always on the bad stuff. So anyway, Marmot Cities, if people who are listening are interested in following that up, it's on the Institute of Health Equity's website, and I think there's been other stuff written about it, and it will also come out in this report, which, as I said, is about to be published. The other thing I want to mention, and I did a series of interviews here, and I wrote a blog about it, is there's a group of people in Wales that have, some people coming out of planning and some people coming out of public health, that have made a concerted effort to start working together on changing how the health impact assessment is designed and ultimately implemented. And health equity is a big part of it. So, back a couple of years ago, when I looked at the health impact assessment here in Southwest London for this project, I never saw anything mentioned about health equity. But in South Wales, there's a lot happening around that. And so they've really begun to, redefine what health impact even means, and to find ways of measuring, developing new metrics and new ways of measuring impact. So that's also something to look at. And I can send you a link to my blog about that, which gives a lot of links to what they're doing. So there is, I think, some activity and going in a positive direction.
That's really excellent to hear. And yes, please share the links that we can direct people to learn more about the work being done by some of the amazing groups out there. And I will certainly be looking up the 12 characteristics of a Marmot Place. I think that probably sounds like essential reading for anybody in the built environment, even if you're not particularly interested in urban health. Talking about the positives, yes, obviously there's a lot of doom and gloom out there, but I would like to understand if you had a view on the impact of what would happen if we don't urgently convene as an industry around health equity and health creation in our places and cities.
I know we all kind of love to adhere to jargon and stuff, but health creation is a really important concept too. And, because it's about, health isn't something that's done to us. We can create healthy places. And I think, often you'll hear, especially now, and I said, I don't want to be dooming and gloomy, but, right now, there's a lot of negative talk around the NHS and the future of the NHS. And well, I mean, you don't have to go further than the Secretary of State for Health himself says it's broken. So, what that does for morale in the NHS is another conversation. But, so there's so much negativity around that. And you also probably hear a lot, and I know he talks a lot about this, that we need to shift from a sick economy to a prevention economy. We need to focus on preventative health and funnily enough, I don't know, now I'm going back to the event in Liverpool. If you remember the plenary address, do you remember it was by Lord Nigel Crisp, who's somebody I know very well. And he talked a lot about a concept, which in fact is the title of a book he wrote. And here I am plugging his book, which is called Health Begins at Home.
Oh, yeah. That's the one thing that I absolutely took away from that conference. And that blew my mind. And also, I remember Sunan Prasad saying that hospitals are very dangerous places.
Yeah, well, yeah, infection.
And that's also blew my mind because to me, as, an everyday person, to me, hospitals are temples of health. But then when you flip the script that no, you should only be going to a hospital if you're terribly ill. Otherwise, you should be in the other nice places in the built environment. Yeah. Prevention is better than cure. Yeah.
No, exactly. And I think this idea of prevention, first of all, it's so intuitive. I mean, I don't think any of us grew up, no matter where we grew up or what our culture was, to sort of say, an ounce of prevention is worth a pound of cure. So this isn't exactly a new concept. But I think when you're, at a point with, you got to remember the NHS in this country, there's a few fun facts that are just worth noting because, it's unique. And I mean, people could say it's unique for a number of ways, but I'll just give you one. Are you aware that it is the third largest employer on the planet?
That I was aware of, yes. And that a statistic also blew my mind. I can't remember who was the first two, but I do.
It's like the Indian Army, McDonald's, Walmart, and I think the US, I don't know, but it doesn't matter. It's like, that's pretty mind-boggling, okay? And then sort of digest that for a moment and then digest another fun fact, which is it is the largest single-payer health system on the planet. Now, so both of them can kind of speak to you. You can say, wow, like you're saying, wow, this is big. Like, this isn't, so to talk about the NHS like it's this single monolithic entity, I'm always a little bit dismissive and doubtful when people talk about it that way, because I'm sure your experience, both, individually and from what you know about other people, it varies so much. We know that. So we don't need to dwell on that point. It's huge. It also means that the opportunities for something coming out of an entity of that scale and that scope are massive. And, I don't even think we've come to the beginning of that, So, and the other point, I guess, is back to the prevention idea. And I'm linking this to health creation, because ultimately, if we really want to have a preventative health culture, and places that actively support preventative health, we have to think about health creation. We have to think about health as something that we make, as opposed to something that's done to us because, we've gotten sick. So that's a really big part of this, that, and that's why I guess I get so animated around the whole conversation we're having around, integrating health into planning, because, we have a new government just, recently put out a budget. What are their two biggest line items? Health and housing. We are literally at an inflection point where, both of these assets, industries, services that are essential to our way of life are at real inflection points. Yet what we need to do is understand how they inform and support each other. And I think that there are just tremendous opportunities for us to be looking at. And I think, that, again, as I said earlier, we probably wouldn't be having this conversation even a few years ago. So the fact that we are moving a little bit forward and, using phrases like, you started this off with health creation, I think we are getting a little bit more understanding of what that means and how it actually fosters progressive dialogue with people.
And speaking of opportunity, you have recently launched a campaign called Build for Health. Can you share a little bit about this campaign?
Well, I think launching it is probably a little bit premature. I mean, it's something I want to do. Everything we've been talking about, and we could probably talk forever about this, I think, we are at this. Well, I used the phrase of inflection point a few minutes ago. I feel that the ears are open, the minds are open. The situations have presented themselves for some progress in this whole regard. I think the report that we're about to release, that I've mentioned through the Marmot Institute with L&G funding it, will show a lot of impact around how the built environment impacts our health, our well-being, and most importantly, health equity across places. What we might do in future to make that happen. But I think we need to build some momentum to keep this dialogue happening. And I think there are a number of ways we can do that. But one of the things that I'm particularly interested in doing is convening a group of like-minded practitioners who feel this way and can begin to have a place where they can talk about it safely, they can talk about it creatively, they can talk about it in ways that are both throwing out new ideas and taking everybody else's ideas and building them into new ones. What that looks like, I'm not really sure, which is why I said it's a little bit premature. But I certainly know, and I think you're probably included in this, a lot of people who care about these issues and would like to find ways of establishing this common language, and some of the touch points we've already discussed, so that it puts pressure is too strong a word, but it influences both government and, as I mentioned earlier, the National Planning and Policy Framework is something that still is under consultation, and we have an opportunity to influence that and around health and health equity, and also influences the industry. So what that looks like, I'm not really sure yet. We actually had a core group going to kick off last week with an interesting group of people, both from design, development, comms for the built environment, a real range. And anybody who's listening to this and is interested in learning more or taking part, do feel free to get in touch, because I think it's something that's really important. And I think we now are at the point where we can have a meaningful conversation around the role of the built environment in our health and what we can do both as community groups, as local authorities, as industry practitioners, and as health practitioners to put these together and create a toolkit, or maybe even like a menu of options that people, like, just take, for example, earlier in this conversation, I said, wouldn't it be great if we had a health impact assessment that could actually be used to support community dialogue? Because, as we both agree, communities care about this. Well, a campaign around building for health could actually begin to put pressure to make that happen, and could actually help community groups to have these conversations with, whether it's the local authority, the planning committee, the planning officer, or indeed the developer. The other thing I care a lot about is having a dialogue and a sort of a menu to work with health authorities, because often they're left out of this. They're just kind of brought into the conversation when, someone needs a bit of data or someone needs a bit of input. But, it'd be very, very useful to build a framework and a consensus around what this could look like.
My interest obviously is in the storytelling and the communication piece around how we get people on board and how we, amplify this Build for Health campaign, however you want to call it, or movement. What do you see as, like we talked about frameworks. So is storytelling included in this framework? How do you see storytelling and communication playing a role in spreading the message about health equity?
That's a really good question. And I think the short answer is I see it as a critical element. And because I've continually used words like dialogue and discussion and engagement. And that's what that's all about is having a common language, a non-jargony language, a shared set of values. That's what makes movements happen. And communication is the essential element. How do you convince somebody? How do you condense, a powerful set of messages into a couple that are really meaningful and are motivating to get people to actually do something and to take some kind of action? So yeah, hugely, hugely influential and important. I mean, storytelling, that's kind of a comment on communications generally. Storytelling is a really, really important part of this too, because on the one hand, while, we want data and we want evidence, we want to show, what the impact of some of these decisions or changes in policy could have, people like stories. And, while stories might be considered anecdotal and perhaps, one-off and perhaps not relevant to me, storytelling does a couple of things. I mean, it diverts people. A good storyteller makes you emotional. So a good story, makes you laugh or cry or both. A good story isn't good if it leaves you emotionless. So I would go so far as to say that. So, but the point I'm making is because it invokes emotion, it gets people activated. Very few people get activated without any kind of emotional, push or, shift, whatever. I also think storytelling can be very unifying, because while you might be discussing something as a matter of principle, cannot always be shared, because somebody might not have the intellectual rigor to appreciate it, or they might not have the experiential background, but everybody can listen to a story. So I think that is a really, really critical point. I could go on and on because I really believe it. In fact, another conversation, but I was listening to something this morning about a company called StoryCorps. And it was on a podcast on my run this morning. And it started off at Grand Central Station in New York City, where people would go into a booth and tell stories. And now they do this kind of mobile service around, but they played a few of these. And it was a way for people. There's sort of, they always say it takes two to tango. There's the listener to the story, and then there's the person to tell the story. And both will have their own unique experience in that. But they can be incredibly powerful ways to change behavior and to bring people together. And I thought that I was really quite impressed when I heard that.
You've touched on something about behavior change. I think that's what most communicator storytellers want to do. And like you said, what we're sitting on in terms of health equity is a big change. So definitely, I think the communicator storytellers out there have a very important role to play in bringing everyone on this journey towards more equitable cities.
No, I agree. And I think it kind of goes back to, the idea of multidisciplinary groups, and different people will come at a conversation about, we all want our place to sustain good health. I might come at it because I care about X, and you might come at it because you care about Y. Do you remember, again, back at that Liverpool conference, and after there was the initial plenary talk, there was a panel. I think Nigel Crisp was on that, and then there were a few others. And it was actually facilitated by this very interesting American woman who I subsequently met. But anyway, she then asked the question, sort of as she was wrapping up the panel, and she kind of asked just the quick fire question: what's the one thing you think is essential to a healthy city or a healthy place? And one guy said, active travel, active transport opportunities. And somebody else said, I think Nigel said, education, and I think he meant that in a health promotion way. But yeah, education. Somebody else said, parks, I think, and, green space, trees. And I think this woman, then she said, healthy food, access to healthy food. And then they sort of brought everything out to the audience. And I literally jumped out of my chair and said, I totally agree with all these, but, there's another element too, which is the role of the arts. It's this whole space of creative health about how, access to beauty and joy and artistic creation and is something that's probably, one of the largest drivers of health inequity, because not everybody gets that. And, it was quite funny because then everybody kind of very quickly backtracked. Oh yeah, that's really important, and it is. And there's a lot of really interesting people. Someone else I think you should interview around this who runs a whole creative health practice. And there's a wonderful health center. I mean, just to do a shout out, but it's a really good example of a healthy place in East London. And there is the most remarkable place called the Bromley by Bow Center, which started off as a simple GP practice and still is at its core, but it's so much more. And it reaches out to the community. It provides arts programs. It provides cooking programs. They have gardens for people. I mean, they really walk the walk on what it means to have a healthy place, and how this is kind of like the fulcrum of a whole set of, various exercises and activities that can be leveraged from that. It's super powerful. And the creative arts are a big part of it. And they also do this in a measurable way. So they will actually look at, for example, in certain marginalized communities, their mental health and how that's actually been impacted through these creative arts programs. So again, it's a huge area. I find it absolutely fascinating. And I think that's part of what makes this whole idea of healthy places so interesting and so important, that we have all this expertise out there. It's a question of, pulling it together and having these platforms for meaningful conversations.
I think I heard about creative health for the first time as well recently, or maybe on the back of that conference. So as someone who works in the creative industry, that's definitely something I'm going to explore and look more to be involved with. But that brings me nicely into the final segment, the future gazing segment of our conversation. So we've talked about so many things: health equity, health equality, health creation, health prevention. What does your vision of a healthy city looks like? If we did everything right, everyone did what they needed to do, what does the future look like?
The most fundamental is it has been led by local communities, that communities feel that they have a voice. And a word that hasn't, or a concept that hasn't come up in this conversation, but I want to make sure it is part of this conversation because it's an essential building block, and that's trust. And, just think about it for a minute. When you, let's just look at it from our personal health. When you go, if you don't feel well or, something's wrong and you want to go seek some kind of, medical help, you trust these people. I mean, that you don't even think about it, because if you didn't, you'd be really worried. Okay. You mentioned one of the other earlier conversations about how hospitals are unhealthy places, like these are things that actually, you don't want to erode trust in places. You want to build trust, and anything that you can do to build trust is going to be essential for living healthy and living equitable lives. It just, to me, that is such a no-brainer. And so to your question, I mean, a healthy city is certainly one where communities feel they have a voice, that they're listened to. And they have had some participation in shaping their built environment. Now, I've talked about things like health impact assessments, and only as a way to bring people in, because when they're not accustomed, when they haven't had those channels to sort of say to you, oh, hey, we're going to change everything now, so we want to change your behavior and come and talk to us about this new, place we're developing in your area, or this new way we're going to change your community. They don't know how yet. So the reason I kind of went on about things like health impact assessments and other tools is a way to invite them into that conversation. And so into your future gazing was your word. A city that's healthy is one where communities have these tools and they feel that they've been able to have some kind of influence on the places that they live. So they have an essential feeling of trust, which means they can do anything going forward. So that's just a fundamental, almost institutional element of what a healthy city looks like. On a more, I don't want to say superficial, because it's not superficial, but, a healthy place has a lot of trees. A healthy place has a lot of, green and blue spaces. Blue spaces to me are, and by that I mean water. I think the food element that I mentioned earlier is an important one. And by that, I don't mean just like, no fast food joints. I mean, a real thought out way of, helping people grow food, helping people share food. Bromley by Bow Center is a really good example of helping people to see that they can take control and participate and enjoy producing and consuming food. So it's a wider issue around food. It's not just, don't allow fast food chains. And sometimes these things get reduced to such overly simplified. And then I guess I would also add in, some of the things I've already touched on. A place that has artistic and creative outlets for everybody. A place that has, primary health and health opportunities for health creation. So, not a dominance on an, acute care or a hospital facility. Yeah, I'd start with those.
I love that vision. I was almost imagining that vision. The moment you said no fast food joints, I was like, ooh, I would like that place. My mind did wander about like, what would that city look like? I mean, and I'm actually thinking after we finish, I'm going to look up to see if there are any places that exist that do not have fast food joints, and what does the quality of life look like in those places. Is some food for thought.
Are you familiar, and I wonder if some of the listeners are, because it's become super trendy. There's even a Netflix series on it, so I guess that proves the point that this is something that's trendy. Are you familiar with the concept of blue zones?
Watched that Netflix series. Me and my family have talked a lot about it. My sister bought the cookbook, so we're very much into increasing our longevity.
The other thing I would say is a nice way of wrapping up your earlier question about what is health equity. I would say we all deserve to live in a blue zone.
Definitely. When I was, I don't think about. I think one of the ones was I think it was a small village in Italy, and they talked about that a lot of people had healthier joints, and because it was a town on slopes. So by default, you'd be walking up and down slopes. And I thought that's genius. So it forces you to exercise. And I thought, yeah, so maybe going to the point about what was said in the conference, active travel. where, you are forced to move. Like I've recently heard a couple of faces like movement is medicine, movement is life. So I'm also very much now on a more personal health journey to flip the script and introduce movement, subtle movement into my everyday. Because at least a lot of us work sedentary office jobs, as you say. We're sitting in our chairs. We spend so much of our time sitting. Sitting is the new smoking, is also something that's been shared.
No, I completely agree. And it feeds back, like, to do that and to have had that decision that you've taken as an individual to embark on that personal journey, that could be facilitated through, public health programs. So once you've made that decision, but then you want the place where you can actually, undertake those activities that, you've made a decision to embark upon. And, it's having the kind of safe, and I don't even mean, beautiful is a nice thing to have, beautiful trees and beautiful landscaping and all that, but safe. Just take the basics. If you want to go walking more, you want to go running, you want to go cycling, why did we introduce bike lanes in London, as a part of an active travel spare? A lot of it was simply about safety. Why were people not getting on bikes? They didn't feel safe. And so it's that kind of first step. And I think, back to your question, what does a healthy city look like? I mentioned the word trust. It's also got to be safe, where everybody feels that they can undertake these activities that will lead to better health creation.
Absolutely. And to your point, I personally do not feel safe cycling in London, and I cannot do it on my own. I can only cycle with someone else in tandem, even on the cycle lanes. I'm very much a person who can only cycle if I'm not sharing the lane with motor vehicles. But anyway, yeah.
Everybody's got their thing. But I mean, even if we go to the most basic of, walking more, you need to feel safe. You need to feel that there's a place you can undertake that and not feel threatened and get all the physical and mental health benefits from that.
Now I'm walking more. I'm very much a get your step count in every other day person, and I have to, as a woman particularly, have to really be careful about where I walk on my own. And like, even if I'm going out with my headphones in, my husband will say, don't put headphones, pay attention to surroundings. And I was like, okay, it's the things we take for granted. But yeah, we should feel safe in undertaking active travel or just wanting to go about doing such basic activities.
But, even just to the point, I mean, not everybody likes to cycle. I mean, you've, evidenced that just now. You like to walk. There's another thing that, there are team sports and opportunities to do. It's being able to find what gives you that pleasure and is going to enable you to stick with something. And, one of the things that, again, another shout out here that I'm very involved in is a movement. It's actually a global movement called Swimmable Cities. And it is a movement to improve our waterways and to, swimmable cities it's not so much about building swimming pools. I mean, it kind of is, but it's really focused on how do we ensure that our cities are swimmable in in its own natural waterways. And it's something I'm very, very committed to. And I think, back to this conversation of what does a healthy city look like? It offers these opportunities for you to make that personal decision about your health and to be able to literally exercise it.
Gosh, do you think we'll be able to swim in the River Thames in our lifetime?
I do.
You're definitely one.
A lot of people do.
I live by the river, so I would love to just,
Are you aware of a project called the Thames Lido Project? So the idea is to create like a floating Lido in the Thames near Bankside. It's kind of modeled on what they did in Paris a few years ago. But of course, Paris is like the exemplar now of swimmable cities. I mean, that challenge that they gave themselves to, clean the River Seine so that, at the Olympics this summer, they could have the bigger swimming events in the Seine was just extraordinary. I mean, it's just a determination to do something. It's kind of like the way they just reopened Notre Dame.
I'm definitely going to mull over whether we'll be able to swim in the Thames in the foreseeable future. Well, that's been an amazing conversation. I've certainly learned a lot. I've been scribbling notes, if you've been noticing, and there's a lot of food for thought for our listeners as well. But before we get into the fun part of our conversation,
but we are having fun.
We are having fun, but health it's a serious topic. So What's next for you? What's next for Clare Delmar?
Well, I really would like to get this build for health campaign off the ground. So yeah, this definitely is an invitation to anybody who shares some of the things we've talked about, or shares an interest rather, and a drive to progress some of the things we've talked about, to do get in touch. So yeah, I'm going to be focusing on that. I'm also hoping to undertake some more research around the role of developers. So something else I'm particularly interested in, and again, this is just to register here, but we haven't really mentioned it specifically, but it certainly contributes to healthy places, is I think most of your listeners and you would be familiar with what we kind of call as an umbrella term, developers' contributions. So when a developer receives planning permission, usually for a big-ish scheme, there will be an expectation to a legal obligation to contribute to some sort of fund for community benefit. So I'm being careful with my words because it's always changing. But right now we have two. We have something called the Section 106 agreement, and then we also have something called a community infrastructure levy. And they're similar but different. And again, you don't need to be burdened by the detail. But the point is, developers' contributions. And one of the things that I've been particularly interested in lately, and I'd like to investigate more. And again, if anybody else has anything that they'd like to contribute about this, I'm all ears. There's a lot of this money that's already been committed but is unspent. And, there's a big industry organization, I'm sure you're familiar with it, called the Home Builders Federation, HBF. And they represent most of the house builders, which a lot of people say, boo, hiss, we hate you. Actually, the Home Builders Federation is, there's some good stuff that they do. And they did a report really recently, by the way, like weeks ago, not months even. Again, easily findable. And the reason why it was so, I think, monumental is because there was no existing data on this. So they had to go through a whole bunch of Freedom of Information requests to get the data that was used to compile this report. Anyway, the subject of the report is this idea of unspent Section 106, unspent developers' contributions. And then there's somebody else who's taken that and drilled down even deeper and has actually seen where this money that has been committed for primary healthcare practices, so now we're getting back more deep into the health impact, have also not been spent. And so I'm really interested in how we can begin to unleash some of this and how we can have, so I talked about health impact assessment as a kind of a forum for dialogue. Equally, I'd like to understand better how these developers' contributions might be a small step forward to build this kind of trust. So that is definitely something I'm looking into.
Excellent. So keep watching this space. And if anyone's interested in what Clare has mentioned, do feel free to reach out to her directly. So Clare, let's dive into the Know Your Neighbourhood quiz. And your neighbourhood is Mortlake in southwest London, along the River Thames. So the way it works is I'm going to ask you 3 facts, if you like, and all you have to do is say whether they're true or false and why you might think they are true or false. It's as easy as that. So fact number 1.
Okay.
The name Mortlake is believed to come from Old English, where mort means a young salmon.
No, false.
That's actually true. That is actually true. On my notes I have, in the early 11th century, there was a fishery in Mortlake. The village could therefore have derived its name from its association with fish farming from the 10th century or earlier. The fact number 2, Richmond Park is the largest urban park in Europe.
Oh, gosh. It's definitely the largest of the royal parks. I can certainly say that. Is it the largest in Europe? I'm going to say no.
What I have on my notes is it is true. So Richmond Park is a national nature reserve and London's largest royal park, as you said, as well as the largest urban park in Europe. The park has an area of 2,500 acres and has been designated as a site of special scientific interest. I think the reason why most of us who don't live in southwest London go to Richmond Park is to see the deer. That's one thing I love going to Richmond Park to see the deer in the wild.
Yeah.
Yeah.
No, we're really lucky to have that. It's just a beautiful place. It's not words. In fact, around here we also have Kew Gardens, and so we have a lot.
A very lovely place to enjoy nature's many gifts. All right. So fact number 3, according to Rightmove's Happy at Home study, Richmond upon Thames has been named the happiest place to live in the UK in 2024.
I thought it was Teddington that was named the happiest place. So I guess I'll say that's true.
Okay, that one is false. So, so you did get it right. You did get it right. I mean, it was false. So, Rightmove survey revealed that Woodbridge in Suffolk has been crowned the happiest place to live, with Richmond-on-Thames in London taking second place. So not bad, not bad. You're in the second happiest place to live in the UK, and Hexham in the northeast securing third.
Also, probably one of the healthiest, to wrap it all up into the health. It's. I think that has been documented pretty well. But yeah, and again, for a lot of the reasons we've discussed.
To your point about it's one of the healthiest and now happiest, that's why it's such a desirable place to live in, and also a very expensive place to buy property. So maybe a subject for another podcast are healthier places, more expensive to live in. Again, going back to then life expectancy. Oh my God, we're gonna need a whole other podcast to discuss about.
I know. I mean, there's so much to unpick in this. It's so true. It's so true. But actually, yeah, just on you just mentioned life expectancy. I talked about that earlier on. Yeah, I think in Michael's 10-year update on social determinants of health and life expectancy, there's 2 points. One is it's actually declined, and secondly, the regional variation, and even within London. I mean, life expectancy of somebody in like Lambeth versus Richmond is, I think, like more than 5 years. You asked early on, what is health equity? That's not health equity.
At many conferences as well, like, on the district line, the further east you go, your life expectancy drops every tube station. So no, that's not something we should be celebrating in any shape or form. It has been such an inspirational conversation, and so much that I have learned, and I'm sure so much food for thought, and a lot for our audience to take away as well. So thank you for being part of our Talking Place podcast.
Well, thank you. It's been really fun.
I guess let's watch where the Build for Health campaign or movement takes us, and how we can make this subject more accessible.
Yes, and I very much welcome your involvement, Tanisha. So thank you for that.
It's a pleasure. So Claire, we'll see you soon. Thank you. Well, I hope you enjoyed this episode as much as I did. I'd love to hear your thoughts. Feel free to join the conversation on social media with the hashtag #TalkingPlace. I would also love for you to leave our podcast a review and subscribe to all our podcasts and YouTube channels so you don't miss an episode. There's so much more to explore when it comes to creating good places, and I'm excited to do a deep dive into other topics with you in our next episode. I'm Tanisha Raffiuddin, and it's been my pleasure to be your podcast host. Thank you for listening. See you again next time, where we'll continue Talking Place. Talk soon.